I'd like to get started. Welcome everyone to the HCRC Lunchtime Talks on the second Tuesday of April. And we're excited here to have Nancy Sherwood from the School of Public Health and the Healthy Eating Center at the University of Minnesota. First though, I just want to reflect, I certainly understand, and we at HCRC really understand the challenges of today and the intense sort of, reflection on the tragic, police shooting of Dante Wright. And I think we all just want to reflect and sort of remind everyone that it's important to reflect, but also to maintain our sort of, social action agenda, to eliminate all forms of inequality and racism and racial injustice in the society that we live in. And I think the community-oriented approaches that we're going to be have talked about for the last year in HCRC, hopefully will make some difference as we move to advancing our world for everyone in a better way. But with that, without further ado, I just wanted to thank Nancy Sherwood. Maybe if we think about healthy eating and childhood obesity prevention, the first person I turn to is Nancy Sherwood, who's been on the steering committee of HCRC for the last couple of years. She's really helped move us to more of a health promotion, childhood obesity prevention work. We've been doing work in that, for many years. And Nancy has a great interesting history, being a clinical psychologist by training, moving into, community-based work with children and families, and especially, with her program Networks, which is a phenomenal community and child family-based intervention, exactly the kind of interventions we need in, movement towards social change for health promotion for everyone, in society. And so Nancy, is great to be here. Again, I know you presented before, but, we'd love to hear some of the updated work, and welcome, Nancy, and take it away.
Great, thanks so much. And I'm glad you started with your comments about just reflecting on what's happening, just because I know even as I was working on this in the past day or so, I was my sort of usual enthusiasm for my work was a little bit diminished, but I do like to think about the work that we're doing. I mean, it's a lot focused on healthy weight, but really it's focused on kind of child development and sort of family resilience, and which is something we all need. So I'm going to share my screen again here. Okay, can everybody see my slides okay? Okay, so today I'm gonna be talking, my titled my talk, Integrating Child-Focused Healthy Weight Interventions in Healthcare and Community Settings. And what I'm gonna do is talk about three different trials that we did. Two of them are very interconnected, and then the other one is the Networks trial. So I'm going to go through them, talk a little bit about the design and what we found, and then talk about kind of one possible direction for helping make our work more effective. There's lots of different directions, and I hope I want to make sure to have time at the end to talk a little bit with everybody about your thoughts and ideas. Let's see. Okay, so I'm just gonna hop right into it. We all know that childhood obesity in adult excessive weight in adults is a public health problem. So we're all starting from the same place. So I'm gonna go right into talking about two different studies we did, which have now been a couple of seems like a couple of years ago. But I think it's part of what I'm trying to do is sort of show kind of where we are in the field to date and kind of what are some ideas for moving forward. So before I came back to the U a couple of years ago, I was at about 14 years at Health Partners Institute as a researcher there. And that's where these studies were conducted primarily. And what we were interested in was trying to leverage the role of the healthcare setting to address obesity in kids, obesity prevention in kids. And a lot, I'm not quite sure exactly what the familiarity is in the audience with this literature, but the healthcare setting has been talked about as an important place to be addressing healthy weight for both kids and adults. But at the time, and even still, like, it's really been an underutilized setting. So what we were up to in this series of studies was trying to figure out kind of how do you leverage the role of the pediatric care provider, and what do you pair that role in terms of addressing healthy weight in kids with, because as we know, well child visits are pretty short, and the problem of healthy weight and nutrition and physical activity isn't going to be addressed totally in that setting. And so we had decided at the time, and it's sort of funny now in our world of Zoom and doing everything by video conference and telephone, but we were, I don't know, maybe we were slightly ahead of our time because we were interested in doing phone-based intervention because it was a way to make things more convenient for parents to participate in. So that was what we did. So we had actually done a little pilot work before we got these two studies funded, but I had two studies funded at the same time. I guess I knew how lucky I was at the time, but not not fully, to have our R01 and an R21 study funded at the same time on this topic. So the R01 was focused on at-risk 5 to 10-year-olds, and I'll define that in a little bit. And then we had an R21 that was generally using the same approach, but that was focused on preschool age kids. Okay, whoops, did I go too fast? Oh boy. Okay, yeah, here we go. So this slide just tells you a little bit about who we were defining as at risk. And we were defining in the 5 to 10-year-old study between the 70th and the 95th percentile. So if you're really familiar with the definitions in childhood obesity, that includes kids who are in the higher end of the normal healthy weight range, but also includes kids who are in the overweight range. And that 95th is trying to prevent progression to that category of obesity. In the preschool age study, we had a slightly different criteria for that, and including the risk, taking into account the risk by virtue of having a parent who is in the overweight category. A little bit about that. And in both of the studies, we had a contact control condition. This isn't something that is typical in obesity intervention trials for the most part, but we were able to control for time and attention, and also examine the effectiveness of a kind of a safety injury prevention focused intervention. And so we always like to have names for our interventions. So our preschool healthy eating intervention was Busy Bodies, Better Bites, and Healthy Tots and Safe Spots for our safety for preschool. I guess we didn't have as good a name for our older kids. And this tells you a little bit about our conceptual framework for our interventions. So what we're doing is we're combining, on the left side, the role of the pediatric primary care provider, and how we thought about this is that, really the role of the pediatric care providers is kind of to start the conversation and provide, as is part of the guidelines for pediatricians, anticipatory guidance around healthy eating, physical activity, less screen time, healthy weight, and also theoretically, although I don't think we did this very well, is to be able to have feedback between what's happening in the phone coaching and the pediatrician to be able to reinforce progress. And then the phone coaching is really what we were doing to more directly support the parents in making changes in the home environment to support children's higher levels of physical activity, less screen time, and promote healthier dietary intake patterns to ultimately influence weight status. This slide shows how a little bit of our timeline. So we, it was because the, and I won't go into the, like all the extreme detail about it, but because the part of the intervention was what is happening in the well child visit, we had this whole system where we were, and this is one of the advantages of being a researcher at Health Partners and being able to have our programmers who could use the electronic medical record and claims database to do this kind of thing. But we were able to, for example, in this study, identify kids who looked like they were in our age and weight range, who were scheduled for a well child visit, and able to kind of recruit them and do home visits with measurement so that they could be randomized prior to that well child visit, and that could be part of the intervention that we were studying. So this is for the 5 to 10-year-olds, which again was the R01, where there was a well child visit component, and they had phone coaching over the course of the first year of their participation in the trial. And then we had a year of follow-up with no treatment provided. Oh, am I going? Wow, I guess I forgot how quickly I cut to the chase. That's why I'm able to talk about 3 trials in this 1-hour talk. So what did we find? Not what we hoped, that I can tell you. So you can see here, gotta move you guys around on my screen, that the patterns of BMI percentile change over the course of the intervention period from 0 to 12 months, and then the no treatment follow-up. I mean, they're going down in the right direction, but the pattern is the same kind of regardless of whether they were in the healthy eating condition or the safety contact control condition. And okay, but I have a strong interest, and you'll see that as I talk about some of our next step ideas, in really trying to understand response heterogeneity to interventions. And in all of my trials, in addition to the main outcomes, we typically pre-specify potential moderators of treatment effect. And so, one of the things that we were interested in is whether, and you could think of all the reasons why we might be interested in looking at differences in outcomes for girls and boys. And here, what we had pre-specified sex as a effect modifier, and showed that among the girls that we did see an intervention effect at over the course of time, but not in the boys. And again, there had been some precedent in the literature and some consistency of showing that there was an intervention in healthy weight related prevention interventions. There have been shown to be effects in girls, but not boys. So then we, oh, oops. We then, the Healthy Homes, Healthy Kids, our preschool study, our 21, we also found that overall, and just here, I realized I didn't describe this in detail, but we were in the Healthy Homes, Healthy Kids preschool study because it was an R21. We had a smaller sample size, and also we only followed kids for 6 months. And what you can see here in this slide is that, well, I didn't show you the overall effect, but we didn't find an overall effect of our Busy Bodies, Better Bites interventions. But when we looked at the outcomes by the weight status of the kids when they started the study, we did find, and you can see it in the top, that we did show intervention effect just in the kids who were already overweight at baseline. And so if you recall, there was kids in that category between the 85th and the 95th percentile. And then the other kids were ranged from the 50th to the 85th percentile. And this was just over a period of 6 months. So that's what we found in those studies. The next study, I'm going to spend a little bit more time on our networks trial and kind of tell you, whoops, sorry, my U of M timing out thing was there for a sec. So networks was a bigger trial. I have, and this is just on this slide, is just a small number of the people involved. My colleague, some of you may know her, my colleague Simone French and I were co-principal investigators on our networks trial. So just a little bit of background about networks and what we were part of. So networks, our grant was funded by NICHD, but the larger consortium was primarily funded by NHLBI. And we were the COPTER, we call it for short, Childhood Obesity Prevention and Treatment Research Consortium. And so there were 2 of us who were doing prevention trials. Our colleague, Sherry Barkin at Vanderbilt, was the other PI of the other prevention trial. And there were 2 treatment trials at Case Western and Stanford, and then Chapel Hill was our coordinating center. We were funded for 7 years. Again, it's great to be able to have that kind of opportunity. There was a pilot phase and then the 3-year main trial phase. A little bit of context for where where we were at the time, and I would argue we're on, I mean, even after the giant investment of NIH, we're still kind of here, that most obesity prevention trials to date had modest results. They typically had been conducted in single settings. A lot of the work that had been done prior to when we started networks had been conducted in school settings, and sort of by virtue of that, there was limited parent involvement. And we were, especially in the preschool age, and there had been some studies conducted in daycare centers and preschool settings, but we were really interested in how do we better reach and engage parents. And then also, because we know that healthy weight nutrition, physical activity, it's not like you can sort of give people a short dose of something and have it have long-term effects. So how do we are, in tackling obesity, we want to be thinking about how can we have a high level of contact and sustained engagement over time. So we put together, and this was kind of, again, based on work that both Simone and I had been doing. I'd been working in the pediatric primary care setting, as I shared some of the trials that they weren't completely done of course, the exact timing of things is now a little bit foggy to me. We were, I think, in the middle of them as Networks was starting. So we were interested in the pediatric primary care setting. We were also interested in home visiting. So I'm assuming, I don't know if I can only see sort of some of you, but any nods or of that familiarity with home visiting literature. But we know that especially at that time, there was had been a lot of work published on the nurse home visiting model, and we were interested in sort of building on the home visiting model. And interestingly, at the end, I hope we could talk about this a little bit, because there's actually an RFA out right now that is due in June, that is you sort of building on home visiting to improve cardiovascular outcomes in mothers and children. And so I'm interested to talk to folks about that, and if there's any interest in this group in working on that with us. But so we were interested because home visiting is also what we were interested in, is trying to sort of see where are existing places and programs where parents and children are, that we can really integrate our messages and intervention strategies around physical activity and healthy eating, so that, theoretically, if we can show what we're doing is effective, it could be, these intervention strategies could end up being sustainable. And along those lines, we also, Simone had been doing some work with early childhood family education and community-based parenting classes. So ECFE classes already, to some degree, include, like, when you think about sort of that birth to school readiness phase, a lot of there's what kids are eating, how they're spending their time, all of those things are a part of that. And so that was another sort of way we were thinking about how do we kind of accentuate those and strengthen those messages in the context of community-based parenting classes. And then also at the time too, there were, and still now, like, more and more attention to neighborhood resources around healthy eating and physical activity, recognition of food, like sort of the concept of food deserts and so forth, and a lot of community-based initiatives to sort of help with those things. But if parents aren't aware of them or not using them, they're not going to be effective. So that was sort of another part of our intervention model. And here again is just a rough little diagram of what we were up to in our intervention. So there was this brief role, and we recruited from pediatric primary care, and we worked with, in this study, we worked with some of our health partners clinics that served low-income, ethnically diverse families. But we also partnered with the Children's Hospital of Minnesota clinics and Hennepin County, well, I guess it was HCMC then, I think it's Hennepin Healthcare now, but they're pediatrics and primary care clinic and family medicine clinics. And so that was sort of the entree point into the study. And then the core of the intervention was our home visiting. And we called our home visitors family connectors, because we were trying to have the family connector not just be doing the home visit, but sort of being the connector across all of our intervention strategies. We had developed our own sort of version of ECFE parenting classes. I'll tell you a little bit about how that went. And then we had all kinds of information that was sort of continually updated about neighborhood physical activity and nutrition resources that we were connecting the parents to. And so the idea, again, was to really primarily, we did some, there was some involvement of the preschooler themselves, but a lot of it was really parent directed to help modify the home environment, was how we framed it, to influence both parenting strategies and the home environment around food, physical activity, screen time, et cetera, to influence child behaviors and BMI. One of the things that we also really talked about, emphasized, was the connection between physical activity, healthy eating patterns, less screen time, and sort of whole child development and school readiness. Thinking that, for the other, obesity prevention isn't like super on the top of everybody's list. And so we're really trying to connect what we're focused on with the things that, one, they are really connected to, and the things that are important for parents.
Nancy, can I ask you one quick question?
Oh, yeah.
I'm really fascinated by the neighborhood dimension. I wonder, in this intervention, what percentage of the time or the resources, goes into that neighborhood community resources? I'm just curious, because I think that's a really important dimension, of course, giving our context today.
Yeah, I wish I could easily quantify that, but it is actually potentially quantifiable, because we collected a ton of process evaluation information, including tracking all of the like referrals and like things we did. I'll tell you more in a few minutes too about what happened with our parenting classes and how we tried to adapt and sort of create different community connection events, because the parenting classes, in a way, were kind of one of the ways we tried to bridge between the community resources. So one of our strategies that we would do would be to have somebody from like the Parks and Rec come in and do a class in our parenting class. And then that was a way of helping parents learn about what was available in the community. We also, like, one of the things we did too was we partnered with the YWCA, and our parents, so there was a sort of a little part of our parent class kind of intervention that involved actually going to the Y and having swimming lessons. So we have like a incredibly rich data on those kind of community connections, but we haven't focused on it in the way that I could tell you the answer to your question. Exactly.
No, that's really fascinating. I would commend you for that approach, because I think we need that for certain programs. Okay.
Yeah, and so there's so much to. Right. So much. So the actual trial was a two-arm randomized trial, and it was a 3-year parent-targeted intervention. In this study, we did not. It was kind of our full everything we have, kitchen sink intervention, as I've described, compared to usual care. So there was not a contact control condition. That would have probably been impossible to do in this context. And our primary outcomes, we were looking at BMI at the 24 and 36 month time points. That was how we specified our primary outcomes. And we had secondary outcomes here. We looked obviously at dietary intake and some of the key aspects of dietary intake, physical activity, screen time. We measured physical activity using accelerometry. Actually, I think anyway, I recognize some names here, so on the Zoom, so I know some of you are very familiar with this. And then we also have, as I mentioned, pre-specified some moderators. We were interested in kind of based on our work to date in the literature, we were interested in starting weight status. We were interested in males versus females, interested in age. And then we didn't, the race ethnicity was a little bit more after the fact when we enrolled half of our participating parent-child dyads were Hispanic. And so that became something, once that we had our enrollment, that was something we were interested in. I should also mention that as I mentioned, we were focused on whole child development, and we had other measures that I'm not talking about here, including executive functioning, and then also we were interested in and did get a follow-up grant that we're in the midst of a 5-year data collection point, and we have measures of hair cortisol because we were interested in how does sort of adversity get under the skin and influence cardiovascular risk, but that's beyond what I can talk about today. So these were our we partnered with the clinics that I talked about. These were our eligibility criteria and a little bit about our data collection. We ended up enrolling 534, enrolling and randomizing 534 parent-child dyads. Sorry, the way I'm trying to move my pictures over. You can see we had amazing retention rates. This we had here, what we're counting for saying somebody was retained is that we had a measured height and weight at them at that time point. So we had over 90% of the kids who we enrolled, we had their BMI data. So that was very exciting and also important because, again, we were part of our consortium, and I feel like that ended up being helpful. So the kids on average, as you'd expect, they were about 3 at baseline. You can see the race ethnicity data that I mentioned, and that about half of the kids who were enrolled were already in that overweight category using that BMI percentile cut point of the 85th. You can see that we did have a higher income cut point than you would think of when you think of a low income sample, but we had the majority of our families had a household income of less than $25,000 a year. And you can also see from here, higher rates of participation in SNAP and WIC, and also that 76% of the parents who were mostly mothers were in the overweight category. This is what, this is one of our, I mentioned we have a very rich process evaluation. Here, I'm just going to be talking about participation and in terms of attendance at the various intervention activities. And you can, oh, sure, sorry. So you can see that the total contacts is in the purple, the home visits are in the red, the blue is the parenting classes, and the connector check-ins. I didn't talk about those, but those were mostly phone calls or substantive interactions via phone, text, or email, sort of interspersed between the other contacts. And you can see, like, in the, our intention was to have a continuous dose, high dose of intervention, across the period. And you can see that even though that was the intention, you know, it decreased over time. But the average number of contacts in the first year was 15. And you can see that we had there was a dip between year 1 and year 2, but like we sustained a fairly high on average. Of course, this is just the average, and there's some families that were high participators and so forth. But this is just one way of looking at it. But we then sustained home visiting over the course of the intervention. Most noteworthy here is, or not most noteworthy, but one thing I want to call your attention to is the parenting classes. So you can see that we did not have as much success as we had hoped for engagement in the parenting classes. We did everything we could in terms of trying to make them at, you know, convenient times and locations. We provided transportation, but it was just really hard. The idea had been to create synergy between the home visiting and the parenting classes, and that for those who attended parenting classes, that worked. But it was just really hard. Different parents have different schedules and it just was, so that's one of the reasons we sort of had to be creative and evolved sort of that component of what we planned. Primary outcomes, oh, look at that, not what we hoped, right? So this is the primary outcome is actually straight BMI adjusted for age and sex. You would expect that BMI would be increasing, but ideally we had hoped that it would change at a different rate in our intervention group, but it did not. If you recall, though, we did have our pre-specified moderators, and what we didn't see anything going on with different patterns of weight change over time for age and sex, but we did with our weight status at baseline and our child race, ethnicity. And let's see. And this slide shows the BMI percentile results. So you can see that for the kids who were not in the overweight category at baseline, the lines almost overlap. But for our networks, am I looking at this right? Sorry, I haven't looked at this in a while. We see a different pattern of results for that looked like there was a more positive effect for, although the kids start out heavier, and I won't go into all the different sensitivity analyses we did, but there was better sort of maintenance and in the networks condition. And then when we looked at the Hispanic versus the non-Hispanic kids, we see that you can see that the kids on the right side of the slide, there's sort of a little bit of a crisscrossing, and there's some evidence of a small effect in our Hispanic families. This just summarizes some of our results of our secondary outcomes, and these aren't moderator effects, they're overall effects. We see there was an effect for, I'm going to go back to this slide, total energy intake and added sugar. It's, one of the things to be, to know though, is that the total energy intake was not an objective measure. It's based on 3 days of dietary recalls. And so we didn't find an effect for accelerometry, which was more of an objective measure of physical activity. Interestingly, our colleagues at Vanderbilt found the exact same effect, like magnitude of the effect. So, maybe I don't know what to make of it, but I don't put a lot of faith that in these results. Added sugar was sort of a similar pattern. We did have a little bit of something going on in terms of the TV hours per day. But again, this is based on self-report. So I just sort of take it with a grain of salt. So, we concluded that the intervention didn't seem to be effective. Overall, there was some hints in some of our subgroups and some of the variables, but it was not the results we had hoped for. And I should also mention that this was across the consortium, the other prevention trial. We actually had more promising results than the Vanderbilt trial did. They had their intervention, the intensity of it was very concentrated in the beginning. For what that's worth, the Cleveland folks and their older kids didn't see an intervention effect. There were more promising results at Stanford, and they had a model more similar to ours. But that just a little bit about that. So I'm want to talk just a teeny bit, and so I can have time for questions about sort of one of the things that I'm thinking about in childhood obesity research. Again, this is the status of intervention research. We see these sort of moderate results. We see some response heterogeneity. It's not always consistent across study. There's some patterns, like in the preschool, if you're in the normal weight status, that doesn't, like, we're not influencing that. If kids are already heavier, we may be able to. Results in treatment, which I didn't talk about at all, are a little bit more promising, but there's definitely room for improvement. I've found this a while ago. Normally I'm not an optimist, but in this case, the glass is half full. So like, these modest results, how can we sort of think about that positively? And this is where I start to think about adaptive interventions and SMART trials, which I've done in adults and haven't yet done in kids. Maybe I can't see all of you, but I'm just kind of curious if I can get some kind of signal from the crowd of who's familiar with SMART trials and adaptive interventions. Some? A little bit? Okay. So basically, adaptive interventions are interventions that are basically tailored to try to get more closely towards delivering the right intervention for the right person at the right time. And one of the things, like this is just an example of an adaptive intervention, which is the pediatric healthy weight guidelines. There's different sort of decision rules based on a child's current weight status and how they respond or don't respond to different levels of care. But the thing is that most interventions that are like adaptive interventions or sort of algorithms for interventions are just based on like people's best hunches about what you think you should do next and when you should do it, and not based on empirical principles or data. And that's where the SMART comes in. And again, I knew I was trying to pack too much in, but basically the SMART is using randomization and re-randomization to kind of get closer to that question of what's the right treatment for the right person at the right time. And again, I won't talk about this, but you'll have, if you're interested, and you guys can have access to the slides. Best Fit is a study that we just finished up that is using the SMART to try to get a better adaptive treatment for adult weight loss. So in this study, we're looking at whether what treatment is going to be better for people who are not responding to treatment, and also when should we do it. So this is just the study design, but I forgot we're almost done. And another cool part about a SMART is then there's sort of the main questions you're interested in, but also looking at whether there are certain characteristics that predict responsiveness to different sequences of treatment. And this is one of the things that and this is my last slide, and I'll stop here. But like, if you were thinking about this, like, you can oftentimes people in a SMART in SMARTs or thinking about adaptive interventions, think about what to do more of for people who aren't responding. But we also can think about, like, do we really need, like for some of those families in the networks intervention, did we really need to do the full force intervention for that whole period of time? So you can think about a SMART as not just figuring out what we can do for people who aren't optimally responded, but how much could we step down or reserve resources for for families who are already doing well. So there's lots of different sort of things that you could be thinking about, like, when would you know with kids if what you're doing is working or not? What do we know about why people our families aren't responding? And that really is needed to understand how to drive what different intervention strategies we might test, and all different kinds of questions, and getting, again, closer to, we know that there's not going to be, most of our randomized trials are sort of testing one size fits all interventions, but like, how can we kind of move beyond that to be able to benefit, have families benefit more, and also to do it efficiently. So I'm gonna stop sharing my screen. Oh, I rushed it at the end there. I did leave a few minutes here for questions and discussion.
That was great, Nancy. Really appreciate it. I wonder, so is the adaptive interventions, these tailored interventions, is that a response to the lack of effectiveness that we've seen in child obesity prevention programs? And so is that where the field is moving? And is the field giving up on these broader macro, maybe micro and macro level approaches, or is it both?
I think it's both. I don't think this is necessarily where the field is going. I think this is where I have, like, my read of the literature, and that's where I had gone in terms of adult weight loss, because it was sort of like, you want to think about, when is an adaptive intervention helpful? the literature kind of has to be at a certain state to be able to even think about that. You have to kind of know, like, well, what's the typical response to the interventions we do? Who, can we identify people consistently who aren't? Like, how do we think about how to make it better for them? And that's where I think this is that when you look at the prevention literature, when you look at like the investment in copter trials and kind of what we found, it seems to me that this is a direction that could be helpful. It could be, I mean, there's so many different directions. There's like, none of this is addressing the structural things and the macro issues that are driving disparities, right? That's a whole different ball game. But in terms of like, if we consistently, the other thing is like in adult weight loss anyway, you can predict, early on whether somebody's a responder or not, yet we keep doing the same thing. And so I think, this is me, Nancy, that this is a direction that could be fruitful. But I wouldn't say like this is where the field is definitely going. And I think people are still like, even that RFA I mentioned, which is focused on CVD outcomes, there's a little bit of language in there about tailoring, but it is really about like testing big interventions and seeing what their benefit is on average.
Sure. I'd say, we'd be HCRC, I can speak for HCRC being director with Judy here, but we would be interested in hearing more about this RFA.
Oh, right.
We're doing a lot of work on cardiovascular health in the CLS project. I've done a number of studies, including obesity prevention study that just came out in JAMA Pediatrics. I'll send it to you. I think I neglected to send you the study. There's a lot going on, but I think we're trying to sift through, all the things that we're doing, but that's great. But that's just an aside. But other questions, open other questions. I'm going to stop my questions. Just in general questions. Or you can ask in the chat box, as Nicole mentioned.
I have a question, but my husband's also on meeting, so I apologize if you hear some background noise.
Okay.
What are your thoughts, and is anyone looking to see how the pandemic and a year of online learning essentially has affected obesity in this age group? I mean, I know for myself, like adults that I know anecdotally, we're all more overweight now. So is anyone looking at that, and what might the response in the field be to that?
Yeah, that's a good question. I mean, I think people are. I can tell you that so I mentioned, my colleague, Alicia Cunyon-Batson, some of you may know Alicia. She had been working with us on networks, and she got her first R01 is a study following up our cohort at a 5-year follow-up. And we, that data collection was interrupted by the pandemic, but just as many people did, we I pivoted, all these words that we've used in the pandemic, pivoted slightly to collect data to try to understand what the impact of COVID, what is and wasn't is on our families. So that's something that's in progress for us. And she also just submitted for our group a continued follow-up of our cohort that is really trying to understand too how COVID impacted like further kind of exacerbated disparities. So so that's something we're looking at. I mostly have heard of people doing kind of observational research, including this on this topic. I think that that's great to observe that things are worsening, right? But I'm interested in intervention. Interestingly, a grant that I submitted right at the beginning of the pandemic was on parent intervention that was focused on helping kids regulate their smartphone use. bad timing, right? Because I think for viewers, we're like, who cares? Like,
Right.
we're all doing this. But anyway, I feel like the reason I brought it up is because I feel like as we're going kind of re-entering, and it's interesting, I'm by myself in my house today because my daughter is back in high school in person this morning for the first time. And I think there's sort of like re-entry interventions that we need to be thinking about that are in another area that I'm super interested in is actually more like, I'm less interested in like weight per se to be honest. I'm more interested in its connection with other aspects of our lives, like our mental health and so forth. But anyway, I digress.
That's great. That's great. Other questions? You mentioned action orientation. I just want to ask, and maybe might be a longer conversation, but I'm wondering, if you think about melding the different fields here, why couldn't like networks be integrated and adopted in an early childhood intervention like Head Start or early Head Start, and be implemented within an existing system that already does over 500 hours of intervention a year? Or it could be a My Child, like our Child Parent Center is another one. That could you get the extra mileage, and maybe the synergy there could work something. Would you be open to that if there were communities or schools that would do that, would be interested?
Yeah, absolutely. And that's what, I feel like we got a little bit deflated, to be honest, with our modest outcomes, because that is the vision, like, right? We don't necessarily need standalone, obesity prevention. We need integration to help like build on the trusting relationships and all the other things that are happening. So that's really in a way what this in some ways this home visiting RFA opportunity is, actually, to take a lot of what we've learned and what we did in networks and have that be partly the CVD model that we're testing that is hooked into existing home visiting programs.
Yeah, I think the challenge is melding. That's the difficulty. You think about school readiness skills. People don't think of physical health, although they should. They think about literacy and numeracy skills, and maybe SEL. But I think there is in the comprehensive program approach. They look at all those things and they equalize it. And I think an approach that could be a partnership kind of approach. I think there's schools. So I know many schools that would be potentially interested in maybe something. But I know the intervention approach, that's how I think about things too. It's not, we know what's existing, we know what the reality is, we got to change the reality. That is a potential. And I guess, we've thought about that just given our results, because, CPC, Head Start, I guess Head Start maybe could look at health burden, but again,
and there has been
the focus was it was reading achievement. Nobody cared about obesity prevention, but again, as it turns out, or cardiovascular health, but as it turns out, we're seeing effects on those outcomes, major effects 30 years later. So there's something going on there, and I would be interested kind of for further talk about this. And I think it's an implication for the broader field too. By like Healthy Eating Institute, why not think about school readiness skills as a broad array of things, and you could link this up. So I think it's part of the fragmentation. We all want our pet outcome, but we can't think that way anymore, I don't think.
Right. Yeah, I agree. And we are, I actually don't know what the status is, but we are sort of the flip of that, interested in looking at the impact of our obesity prevention on school outcomes. And so.
That'd be great. No, I think it's a long conversation, but it's great. You've really, expose a lot of interesting areas, and just it's great work. Any last questions? I know we're slightly over. Any other questions? And then how can people get in contact with you?
just send me an email. So I'll put it on my slides, and I'm easy to find.
That's great.
Yeah.
Well, I'd like to thank everyone. So we'll post the presentation on HCRC, and you can see the slides as well and other contact information. And certainly we'll be in touch. Nancy, thanks so much for presenting